My lighting was better.
Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Feel free to ask questions in the chat box as we go along, and your questions will be addressed. So today is a special session. We're going to be spotlighting emergency medicine today with Dr. Afra Ali. She serves as the Assistant Professor of Medicine at the University of Maryland School of Medicine with the Department of Emergency Medicine. She actually completed her emergency medicine residency at the University of Mississippi Medical Center, and also another fellowship that she can also talk to you more about at the University of Maryland Medical Center. Dr. Ellie actually serves as a course director for one of my pre-clerkship courses in medical school, and also an emergency medicine elective. And so Dr. Ellie is also an incredible published author and mentor to many students and many different peer-reviewed journals, and she has presented many of her lectures at national and also international conferences. She also serves as the co-chair of the AAEM Simulation Interest Group, and her contributions to the field have earned her several awards, including the AHA the Young Investigator Award, which is amazing. Outside of her academic and also clinical responsibilities, Dr. Ellie, like I said before, is a committed mentor to many different medical students and also residents. And so her passion, I would say, is also fostering the next generation of emergency medicine professionals, and overall, just a wonderful mentor I've gotten to know during med school. So, Dr. Ellie, whenever you're ready, feel free to take it away. Thank you so much.
Hello, everyone. Good morning. Thank you so much for having me here, Manal. This has been a great experience, and I hope people can learn about. I'm going to be talking about seizures today, but before I start off, I'm going to talk a little bit about my own journey to the US and how I got my residency here. I did my medical school at Gulf Medical University, which is in the United Arab Emirates. And I pretty much grew up all my life there. And this was not an easy decision to leave my home and move all over here by myself. But I think I kept thinking about how I wanted to continue my studies further on, and I wanted to do it in the US. We had great educational system here, especially when it came to doing residency. I had to complete my USMLE right after I finished my medical school. During medical school, I didn't really think I was going to ever leave my home, but as I completed it and I started my first residency, I did my first emergency medicine residency in Abu Dhabi. And while I was doing that, I realized I wanted to get a more robust training, and I thought that would be better to do in the States. So while I used to do my residency, which was like 10-hour shifts, I used to try and study before and after for my USMLE. And it is really tough to do that. So if you are planning to move to the US and you are a medical student, I would say start doing it as soon as you realize that is something you want to do. I think I would have had it much easier if I personally would have taken my step one during my pre-clerkship years, during my first and second year, rather than waiting in my sixth and seventh year of medical school, of finishing off medical school. uh, you retain a lot more stuff if you do it sooner, and then your step two is more clinical, so it makes more sense to do it after you finish your third or fourth or fifth year. My medical school was a 5-year medical school with 1 year for mandatory internship before you graduated. So in total, you had to do 6 years before you graduated. And so I had enough time, I think, to do the steps if I wanted to. Um, and then so I had finished about 3 years of my emergency medicine residency before I moved to the US. And then you have to restart everything you do because you don't get credit for it. So I had to start off, and I did another 3 years of emergency medicine. So by now I was probably like a PGY 7, doing, two residencies and 1 year extra year of a nerd job. I moved to Maryland about 7 years ago, and I started off as a clinical instructor. While I was doing that, I realized I still wanted to continue keeping education as my niche and my focus of training. So I did a medical simulation fellowship, which involves learning how to teach simulation. Um, and it's not just the aspect of teaching, but there's a lot of like technical aspects of how to use the simulator, how to use the different mannequins, and how you can use it for different ways in education. And that has been a lot of focus of my career, and that is one of the biggest niche I have, is not only teaching people through simulation, but also teaching people about simulation. I took on the role of the co-chair of AEM, which is the American Academy of Emergency Medicine, go- um, chair group, basically because of that, because I wanted to like teach people what simulation is and how to use it in various ways. Um, I did a teaching fellowship, which was with the American College of Emergency Physician, and this highlights usually the different ways that you can educate in. I am presently doing my master's in health professions education, which again concentrates on the different aspects of how you can teach adults, because adults learn differently than teaching a child. And it has been an incredible journey. And if this is something that you are interested in, then continue listening to TeleShadowing. I know a lot of people come over here and talk about their journey. So I'm going to go ahead and start our lecture today. I'm going to talk about how to approach a seizure. Seizure is an abnormal activity, neural activity that does lead to jerky movements, and we're going to talk about the different kind today. So, this is more from a perspective of an emergency medicine focus. So, I'm going to keep it simple and talk about a couple of the ways we approach it when a patient comes in. So, this is our patient today, Mr. A. He's a 28-year-old male. He had some active seizure-like activity at home, and his family was worried, so they got him in. Um, when he initially arrived, he's very confused, so he's not even able to give us any history. So, what a couple of things that we can do for this patient? So, when the patient arrives, ideally you want to take a history. But in this case, the patient is altered, almost likely post-ictal, which is the phase of after you have a seizure, the patient can be confused, agitated, disoriented, and may not know what's going on till they recover and come back to their baseline. So in that case, what we can do is we can call the family to see if anyone witnessed this seizure and they can tell us more about it. A couple of questions you want to ask, whether that's the family or the patient, is if the patient had any symptoms before the seizure. So this is what we will say pre-ictal phase, where you want to know if they had any headaches or an aura like that they're about to have a seizure. Did they have any nausea, vomiting, chest pain, lightheadedness, any episode that they felt that maybe they're about to pass out? Then you want to ask questions that are more focused on the seizure episode itself, which is what did it look like? A lot of the time, patients may have different kind of seizures, which means they can have either a focal seizure, which is you basically have one part of your body. So, for example, your hand can start shaking and then your entire body shakes, right? But there's a focality of it starts in one aspect of your body and then moves on to become a generalized. And the most common type is a generalized or tonic-clonic, which is you will see the patient stiffen up and then shake, and then stiffen up and shake again. And that episode is often terrifying for a lot of patients. And if you have ever seen anyone have a seizure, it usually feels like forever, even if it is a couple of seconds. So I tell patients all the time that if you have somebody in your family who has a history of known seizure, have the clock started so we know how long it has been. And I will talk about why it matters how long it has been a little bit further on in the session today. So you're going to ask what type of seizure it was, whether it started off focally or it was more of a generalized tonic-clonic seizure. You're going to ask if the patient had any rolling of the eyes, if there was any frothing over the mouth, if the patient maybe bit his tongue, if there was any, if the patient peed on himself or defecated on himself. Um, and another concept that sometimes people forget is this is a very traumatic event physically as well. The patient is having these jolting shakes, and because of that, sometimes they can have dislocation of their shoulders, like a posterior dislocation. They may also fall and hurt themselves. So they may have physical injuries. They may have a head injury if they fell on their head, or if their hand got stuck in certain place or position. Based on that, they may have hurt themselves as well. Another aspect is if they were left on the surface, like for example, they were left on their back for a really long time and they were seizing, they could also aspirate. So they could have aspirated, and that can cause other complications. So ideally, when a patient is having seizure, you need to ask the family, what did they do for them? Most families that have a patient that is known to have a seizure will know that they need to turn the patient either in the left lateral position and kind of keep the head as backward as they can. So kind of do like a chin lift so that they don't aspirate. So you want to know if all these things were done. And then in the postictal phase, you're going to want to know if the patient has got up, he was disoriented, confused, and if the patient had already recovered, you would ask the patient for how long did he have this whole episode for. Um, Now we come back to Mr. A. He is back to baseline. He is more oriented now, and he's able to give some of that history to us. So he tells us that he has a history of known seizures. So again, that's a very important component, because if somebody has a first time seizure, we are going to approach it a little different versus somebody who has had a known history. And we'll talk about both of these things as we go along, as to what would be the different things that you have to be more concentrated on. For people who have first time seizures, we are basically looking very actively for a cause of the seizure. Whereas somebody who has already been diagnosed with epilepsy disorder most likely has gone to a neurologist. They have had extensive workup, including an MRI of the brain and an EEG, which is again important to find out if they have a reasonable focus in the brain, which is causing this activity, which can then help them get further treatment. All right, so we're going to look at what a seizure looks like. Oh, that did not play as I wanted it to. But basically, this was going to show you a seizure-like activity. So
You
if you have
can, Dr. Ali, sorry to interrupt. You can actually play, you can play, go back a slide, and on the bottom, there's a gray play button on, sorry, go, and then on the right, if you move your mouse a little to the right, more right.
oh, there.
That.
Okay. I was like, what? um, hopefully it plays it a
Yes,
little.
it's playing.
Okay.
Yeah.
So this is what a seizure would look like. And you can see the patient is basically having this very exaggerated movements and of shaking, and his body is kind of like stiffened up. So that is like the tonic and the clonic part that we talk about quite often. A couple of things now we're moving on to, like we were talking about, if somebody continues to have a seizure for more than 5 minutes, or if somebody has had a seizure that is just continuously going on and they don't return to a baseline, we worry about status epilepticus. And when you go into status epilepticus, that's a whole different component of how we treat it. So before we move on to any of those different terminology, we'll talk about what are the different causes of seizures. There are some very quick ones that we can quickly reverse, such as hypoglycemia. Hypoglycemia is basically when the glucose in your body goes so low that you will have a seizure. You may get altered, you may have a seizure, and this is a quick fix because if you can do a bedside point of care glucose, and the moment you get the result, you can go ahead and treat it. So this is almost like the fifth vital sign that you need to get for somebody who is altered at any given time. Um, Other metabolic reasons such as hyperglycemia, hypercalcemia, hyper or hypothermia, hyperammonia. So if anyone has a liver disease, they can have hepatic encephalopathy, and they can also have seizures when they reach at a very high level of ammonia. So another component to remember that. Um, you can have neurological causes, such as if they have any infectious process going on, they may have meningitis, encephalitis, a brain abscess. They could have also had a head bleed. So if you have trauma and then have a seizure, then you could have had an epidural hematoma or an intracranial hemorrhage or a subarachnoid hemorrhage. Um, and then thinking about if you have any of the infectious processes that we talked about already, meningitis, encephalitis. In children, there are other causes, such as you can have febrile seizures, but that's only very pertinent to children. And I'm only going to talk about adults today. You can also have vascular causes such as vasculitis, stroke. This could be some of the other differential diagnoses to consider. The other component can also be like if you use drugs of any sort, they can also lead to seizures. One of the major component in patients who have a known history of seizures is non-compliance of the medication or not taking their medications. So if you're not taking the medications, most likely the levels of the medication that should be in your body will be usually lower than expected. And in that case, if you just replace that you know that the patient is having a seizure because they didn't take their meds. However, if they're still taking the meds and they're still having the seizure, then it could be that the medication is just not working for them. So that's another very important component to look through. I practice in Baltimore, and in the US, a lot we have opioid use disorder, which is now an almost like an epidemic in the country. It's a public health issue, and we do see a lot of variants of drugs that are used that do cause seizures, such as cocaine. Um, and other LSDs and anything basically that increases the risk of psychosis can then lead to a seizure. So something again, people who have history of seizures are warned against not um, doing that and taking any drugs because it can cause them to have increased amount of seizures as well. So that is sort of like some of the differential diagnosis that you can think of. Moving on, we're going to discuss about what investigation am I going to do in the ER, because we have limited resources of what we can and cannot do compared to if you were admitted in the hospital, and there's more significant things that you can do that is different in the inpatient service versus doing it in the emergency department. In the emergency department, it's easy to get lab work pretty much stat, which means it'll come back around has a quick turnaround time of like 1 to 2 hours. You can start off with getting a complete blood count, which would show us if the patient is anemic, if the patient has any increase in their white count, if they have an infection. They, however, will also may have an increase in their white count because of a stress reaction because they just had a seizure. Another major component is getting a comprehensive metabolic panel, which will let us take a look at the sodium, because if you have low sodium, that can also cause seizures. Um, you can look at the potassium, hypokalemia. You can look at the chloride. You have the glucose again, calcium level. Uh, it also includes all the liver function tests such as AST, ALT, and then you can also add on an ammonia if the patient has a known liver disease, and if the ammonia is high, then that could be hepatic encephalopathy. A urine drug screen that would give us a better idea of what the patient may have taken if drugs are involved. You can also do an alcohol level, as extreme high levels of alcohol can also cause coma and seizures, ataxia, coma, seizures, altered mental status. Uh, Moving on, you could do an EKG because sometimes arrhythmias also may show up as seizures, and this is a very other important component. Is sometimes people may not know how to differentiate between a seizure and a syncopal event. A syncopal event is transient loss of consciousness, but so basically what we call fainting or passing out. But even though the patient may pass out, they may have sort of like what we call convulsive syncope, which is they pass out and then they have like a seizure-like activity. So you have to learn to differentiate both of them. So it's important to get an EKG and ask that real thorough history, because if usually the patient with convulsive syncope will not will not urinate or defecate on themselves, will not be confused for a prolonged period of time, like a postictal phase. So there are a couple of aspects of the history that will help you differentiate, but also in your workup, you have to think about if I'm addressing this or no. So an EKG is very important to just make sure they don't have a baseline arrhythmia, if any, to be able to differentiate that. Another component is getting a CT or getting any sort of imaging of the head. In the ER, you're going to have a CT scan that is usually available in most ERs. Um, and the CT scan is usually done for patients who have a first time seizure, because this is the first time person we are trying to still figure out what kind of intracranial pathology they may have. I usually do it in high risk patients, patients who are immunocompromised, such as HIV, or patients who are on chemotherapy, patients who have a history of any sort of cancer, because you don't know if that has now metastasized to the brain. So even if they have lung cancer but are not being treated, or even if they're being treated, you don't know if it has metastasized into the brain now. So that is a very important component of just remembering when to do a CT scan. If the patient has had any significant trauma during the episode of the seizure, for example, they fell off a really high bed and hit their head multiple times against certain thing, and when you examine the patient, you notice that the patient actually has physical bruising on their head, that would be concerning, and I would get a CT scan for that as well. When would I not get a CT scan? So one of the reasons I wouldn't get, if someone just had their regular seizure, if someone has a known history of seizures and was at home, sitting on the couch, had a seizure, fell on the couch, and basically was protected the whole time. Someone like that, I wouldn't necessarily CT image, because if this patient has seizures like every couple of weeks, then you're basically radiating this patient that often, especially if they're in the younger age, right? Because radiation also does have its own side effects. You also have to consider that in the emergency department, you don't have a CT scan. So, sorry, in the emergency department, you do not have an MRI. A lot of the time, neurology always would recommend that the patient gets an MRI, which is a much more extensive process of like looking through your brain. It gives you more detailed images. It can give you more aspect of if there are any other reasons that the patient is likely having these seizures. We cannot do that in the ER. So we usually will refer the patient out as outpatient MRI, or we would admit them if they need admission and then have that workup done. Another component of when we're doing workup is a EEG. Again, it's very difficult for us to get an EEG in most of the emergency departments in the United States. However, if you had somebody who had multiple seizures to a point that they had reached status epilepticus, in that case, I would be concerned about them, and then do consider trying to arrange for an EEG. They have come up with new devices now where you don't need a tech to come in and like put in all the electrodes on the head. You basically make the patient wear a form of a cap, which has all the uh, electrodes already attached. And that can kind of give us a spot EEG sometimes. And there are different type of EEGs too. You have a spot EEG, which is basically you put it for a couple of hours and you look at it. And then you have much longer continuous EEGs, which the patient will have continuously placed on while they're in the hospital, usually for 24 hours, to look at any events that may happen during that. And sometimes patients can have what we call psychogenic, non-epileptic form seizures, where they will have what looks like a seizure-like activity, but the underlying cause may be psychological rather than organic. And in those cases, it is important to distinguish if this is causing abnormal neural activities, because sometimes the patients may have both. So EEG is very important in those cases. So there's a couple of workup that you would do. All right, now let's go back to a case. A patient, we go back to a patient, and now he's having another seizure. You see, he's blinking his eyes. He's got some frothy saliva and jerky movements, and continues to have this for a while. Um, and we're going to see like how long does this last for, and we realize that it lasts for more than 5 minutes. So now the patient is in status epilepticus. Let's talk more about what are seizures and what is status epilepticus and how do you treat it. Seizures are basically abnormal electrical impulses that are occurring, that basically cause a seizure in your brain. And then if this goes on for a significant amount of time, if it happens at least for more than 5 minutes continuously, or you have multiple smaller episodes, but between those episodes, you did not gain any consciousness for again more than 5 minutes or so, that is also considered status epilepticus. So usually if you've had a history of seizure, you may have a seizure for like 30, 45 seconds and subsides. You go into your postictal phase where you're confused, disoriented, and then you come back to your baseline. Whereas the other component of having a status epilepticus is when you continue to have these seizures and you don't get better, you don't go back to your normal baseline. There's another component of not having epilepticus, uh, any convulsive form of epilepsy, where basically the patient will just appear to be confused, but may not have that shaking, or he may be altered and may not have that shaky episode where you can visibly see the seizure. And that is also important to consider if someone is just not waking up after a seizure for a prolonged amount of time. Usually they start waking up about like 15 to 20 minutes. They may come back to the baseline in an hour-ish or so. But if they're not showing any improvement, I would be worried about subclinical seizures. Now let's talk about what is the emergency treatment plan for somebody who is having convulsive status epilepticus. In the emergency department, you always want to worry about A, B, C, D, E, F, G. I've written everything. So ABCs are basically airway. So you want to make sure the airway is patent, which so in a lot of patients who have seizures, their tongue basically falls back onto their oropharyngeal area, and that can basically block up their breathing. And so you want to basically readjust the mouth. You can do a chin lift, and you can put the patient in the lateral decubitus position. If the patient still is not getting better, you can put something called a nasal trumpet, which is a nasopharyngeal airway. It's a small tube that you basically put in the nose, and that would kind of help get over some of that blockage from the tongue and help with the breathing. When we come to B, B stands for breathing. You want to make sure the patient's respirations, oxygen saturation are all intact. Usually, when someone is seizing, they will become hypoxic and may not have oxygen reaching to them. So you want to go ahead and just put them on a 15-liter non-rebreather. It's also hard to monitor the oxygen while they're seizing because their hands are going to be moving. So the pulse ox, especially if it's on the hand, it's not going to be able to read it. So just put them on the non-rebreather as long as they're having seizures. Um, C, circulation, you want to make sure you can monitor their heart rate, the blood pressure, make sure they're not hypotensive during this event. So they may need fluids and things like that. And the component that you will see is that they'll start having frothing on the mouth. So you want to kind of use the suction, but don't try to force open the mouth because the amount of force that they might be biting down with is extreme already. So you do not want to try and shove something in because you will not be able to. And the most important thing is don't ever forget the glucose because that is a quick reversible cause that can be treated at bedside. Um, Obtaining IV access and then looking for any sort of reversible causes. Like we talked about all the blood work, you're going to make sure they don't have any of those things. And blood work usually takes a while to come, so you're usually treating even before the blood work comes. You will treat it as a presumed status epilepticus. Till you know the cause, you're going to go ahead and do the same sort of treatment. The medications we're using, the first line medication is always a benzodiazepine, and that is using lorazepam or diazepam. So lorazepam, if you're using it 0.1 milligram per kilogram, a max of 4 milligram, and midazolam, it's 10 milligram. I am once, and then you can repeat it. Mainly patients, a lot of the time, what happens is that patients get underdosed with the benzodiazepines. Like a lot of the time, they may be only given 2 milligram rather than 4 milligram, or 5 milligram rather than 10 milligrams. So appropriate dosing is very important to stop a seizure, abnormal seizure-like activity, especially in status epilepticus. So sometimes these patients can just continue to seize. The second line that we use is tisagenlecleucel, which is Keppra. It's 60 milligram per kilogram IV, and the max dose is 4,500 milligram. Or you can use phosphonatoin or phenytoin, which is 20 milligram per kilogram IV. And then you have valproic acid, which is 40 milligram per kilogram per IV, for IV. And these drugs are basically standard of what somebody may already be on. So, for example, if you're a patient who is on Keppra, which is kind of like the most likely drug most patients are on, and if you're on that drug but you don't take your medications, then it's simple as just giving you that drug. But you already took the medication, you already have the chronic use for medication, you're very compliant with your medications. In that case, we would switch and give you another class of medication. Now, basically, all these medications that are there, you can check the levels by sending the blood work for it, but a lot of the hospitals will not result the blood work within the same frame. Like, so it would probably take a couple of hours rather than 1 or 2 hours, may take like 4 or more hours. So just something to remember that we can send for these, but you may not immediately know whether the patient is taking the medications or no, apart from asking the family and getting a history from that. Now, there has been a trial that has looked at what is the benefit of using each of these drugs and who is a good candidate to use it. Um, the first one, which is levetiracetam or Keppra, is basically very widely used. A lot of the patients use it, given this as the first line medication because of least amount of side effects and least amount of contraindications. The contraindications for phosphonatoin and valproic acid are pretty much kind of similar. They cannot be given in liver patients. They cannot be given in patients who are pregnant. So you have to kind of remember about a couple of those aspects before giving any of these medications, especially because if you give them and they have liver issues, then it will significantly worsen. I personally use Keppra or levetiracetam as my first line for almost everybody, but you can see the absence of clinical evidence seizure and improved responsiveness at 60 minutes is pretty much not a lot of difference. There's no significant difference in the rates of seizures, cessation, or in safety. So I would concentrate on whatever is the fastest available drug in the hospital you are. Most drugs carry all, oh, sorry, most hospitals do carry all the drugs, so it should be easily accessible to go ahead and give these as the second line. Now, this is the most important thing about your prescriptions. If you don't fill your prescriptions, if you don't take your prescriptions, we have a system in our electronic health record system where we can actually look at when patients refilled their medications the last time. If you are not if you don't get that history from the family, or you're not even able to locate where the family is, or not able to look at, then you can look at this chart and see when they fill their medication. So if they haven't filled it for 3 months, okay, they probably haven't taken the medications for 3 months because they didn't get it from the pharmacy. So that's again a very important thing that we can do here. Not everywhere has that capacity, but we definitely do have it with our electronic health system. Now, once we have done, so we went through the first line, patient did not stop seizing. We went to the second line, patient still did not stop seizing. So now we are at that 10-15 minute, and we want to go ahead and do something more advanced. Uh, when we are using more advanced medications, it will cause respiratory depression and worsening of the CNS depression as well. So most of the time, we'll go ahead and have to intubate these patients or have some sort of advanced airway management so that then patient is now placed on a ventilator and we can monitor their breathing ourselves. A rapid sequence intubation is basically what we go ahead and do, and we usually induce that with a medication of that is propofol or ketofol, which is ketamine plus propofol. Both these medications have had known effects in for anti-epileptic properties. So propofol, if used, not only causes the CNS depression and the respiratory depression, but can also have some anti-epileptical properties that will reduce the seizure-like activity. We do use paralytic. Usually rocuronium is preferred. Uh, if Sig- uh, if Sugamadex, which is the reversible medication for rocuronium, is available, or if the seizure duration is more than 25 minutes, otherwise you can use succinylcholine. The other component about paralyzing a patient for intubation is that once you paralyze the patient, the medication usually lasts for 45 to 60 minutes, so you would not be able to see any of the convulsive episodes. So if you intubated the patient, put the patient on propofol, and the patient is still seizing, you would not be able to monitor that unless you have a continuous EEG on there, and then that is the only way you could look at the brain activity. But otherwise, it would be very hard to go through it. Uh, Now, despite doing all of that, at that 15-20 minute mark, the patient is still continuously seizing. We have these refractive medications that you can use in status epilepticus, which basically consists of propofol. You have 2 to 5 milligram per kilogram IV, and then you would actually start an infusion of 2 to 10 milligram per kilogram per hour. You have midazolam at 0.2 milligram per kilogram IV, then infusion of 0.05 to 2 milligram per kilogram per hour. Ketamine, which is 0.5 to 3 milligram per kilogram IV, then infusion of 0.3 to 4 milligram per kilogram per hour. You also have lacosamide and phenobarbital, but usually I usually start with propofol and midazolam, and that usually helps. I haven't had to go down. But if it gets worse, then you can consider consulting anesthesia. You can also consider just paralyzing the patient, which was kind of like keep them more in sync with the ventilator and not have that convulsive activity, and will help induce more of a coma. So this is how an EEG looks like. I'm not a neurologist, so we don't read these. But what we can do is if we do have that device that automatically helps us read, we can go ahead and put that on the patient, and then there will be someone on tele reading, which is basically not in the hospital, but somewhere far away, that will be able to help us read, and they'll tell us when there are spikes in the EEG, and if there are spikes in the EEG, they will inform us, and we can accordingly then change the medication doses that we're giving the patient, or basically you have to increase the medications to cause a medically induced coma so that all neural activity stops. And then a couple of takeaways I want you to have from today's lecture is that you always want to get a bedside finger stick glucose, because this is a very quick reversible it's very quick, this is reversible, and very much can be treated at bedside. Benzodiazepine dosage is 0.1 milligram per kilogram of lorazepam, which is max of 4 milligram. You may see people start off with 2 milligram, but the patient will not stop seizing unless you've given them an adequate amount of benzodiazepine. A lot of the time, people will think that, oh, the benzos didn't work, the first line didn't work, so we should just jump to the second line and the third line. But if you're not giving adequate amount of the first line, that may be the reason why the patient is not, why the patient continues to be in status epilepticus. Second line should always be given irrespective of benzodiazepine, even though this helps, the benzodiazepine helps immediately stop the seizure or sensation. They may have a second seizure if they're not given their regular anti-epileptic medication, because the benzodiazepines also have a very short half-life most of the time. So once they run off, the patient may have another seizure as well. So you still want to give them their longer acting second line medications that they're supposed to be on. So the baseline therapeutic levels in the body are around that area so that they don't have another seizure. All right, that's all I have for today. I'm happy to take any questions, or if you guys have any questions or anything that we have from there.
Thank you so much, Dr. Ellie. Yes, we received a couple of questions. It was a very engaging session, and we really appreciate learning the escalation of the treatment, especially like considering the refractory status epilepticus. And I'll pass it over to Amna to ask our questions from our students.
Hi, good morning, Dr. Ali. My name's Amna, and I'm currently an undergraduate student at the University of Maryland College Park, studying neurobiology and physiology, and I just applied to medical school. It's so nice to meet you this morning. I'm going to be conducting the Q&A session, as Manahil mentioned, with questions received from students about the case, as well as your life and career journey. So, our first couple of questions are about your case. So, what are some key differences between focal and generalized seizures?
So in the focal seizures, you'll see that the patient may have the seizure only in one part of the body, and then the focal can become generalized versus just a focus. So for example, you may notice that the patient comes in and they're completely awake and they will complain of just having activity of seizure-like activity or like shaking-like activity just in one part of the body. Usually it's an arm, where people might think it's a tick, or which is also like an abnormal jerky movement. But in those episodes, usually you cannot tell if it's a tick or a seizure unless we've had an EEG and monitored like where this focal activity is coming from. Um, and usually you can also divide them into like partial seizures where the patient is like completely awake, talking and going away, having like, just one part of the body just taking away. And then that can move on to generalized where it'll go all over the body and then the patient becomes loses consciousness and basically has a tonic-clonic seizure.
Perfect, that makes sense. Thank you. So, what were some of the vitals of this patient? Like, let's say if they have tachycardia and hypertension as well, like a heart rate of, let's say, 110 and a blood pressure of like 155 over 60. How might the patient's cardiovascular status affect his seizure risk or management?
So at baseline, if they already are tachycardic or hypertensive, when they will have the seizure, their tachycardia will go up. So if they were at a baseline like 110, then they may go up to like 120, 130. When they're having a seizure-like activity, the blood pressure also increases. One of the components, like when you have put this patient in a medical induced coma and you notice that the patient keeps spiking up their heart rate and spiking up their blood pressure, that's an idea of knowing like, oh, the patient's probably having a seizure, but we can't see it because we've induced a medically induced coma and we've put the patient on a paralytic.
Got it. Thank you so much, Dr. Ali. Now we'll switch over to the questions about emergency medicine and like your day-to-day lifestyle. So our first question is, what primarily inspired you to pursue emergency medicine over other specialties?
So when I started off med school, I thought I would do surgery, which was more hands-on. I think I, as a human in general, like doing hands-on things. I learn better with visual and audio rather than reading books, to be honest. But when I started doing my when I started doing my surgical rotation, I realized it was a lot of longer hours of standing, which I just don't think I could physically endure for that long. I also miss doing some of the medical components as well. But when I went to do my emergency medicine rotation, it was like a combination of everything. You could do medicine, you could do surgery, you would do OBG, peds. So you saw all sorts of patients, you saw all sorts of cases, and I really liked that variety. It was also a very fast-paced environment compared to like I don't think I would ever be able to go on rounds that last for 4 or 5 hours and talk about the same patient for an hour. It was just when I went on rounds and did cases, it was just so long and lengthy for me. I was like, no, I need something that's shortly focused that I can do quick treatment on and then move on from that. That was the thought process going into emergency medicine. Does emergency medicine only have emergencies? No, you have a lot more people that come in for a lot of convenience care because there's nowhere else to go. They go to the emergency department. So my day-to-day life does not look like the show ER. It does not. I do see patients that are sick, but I also do see patients that come in for just regular stuff as well because they couldn't go to the regular doctor or they want blood work done in an emergency and they want the blood work results stat, which it's usually harder to do if you get it from a lab core.
Yeah, that makes sense. It's pretty common for a person to go into medical school thinking, oh, I'm going to do this, and then they come out setting their mind on completely something else. So thank you. That's probably really helpful for a student deciding on a specialty and keeping an open mind throughout. So our next question is, as you mentioned a few fellowships within emergency medicine, did you pursue an emergency medicine fellowship to specialize?
So I did the medical simulation fellowship, I did a teaching fellowship, but there are different other kind of fellowships like ultrasound, is a famous one that a lot of people do. There's wilderness medicine, there's hyperbaric medicine as well. What else? These are the ones that I remember the most people will actually do. But emergency medicine is so vast that once you get into it, it's not like, how you go to internal medicine and then you can go specialize in like cardiology and neurology. Emergency medicine is it, right? So anything plus you do, it's not going to be something extensive. It's going to be like, oh, having another extra degree in ultrasound or having another degree in. Now they have opened up some pathways where because you've done emergency medicine, you can do sports medicine, which previously only orthopedics or people who've gone into that field could do. There's also, you could do pain management. You can also go into critical care. There's a lot of focus on doing an emergency medicine, internal medicine, and a critical care residency, and that gets all done together for 6 years. It's a longer pathway, but you get triple voted. So things like that are available. I did consider there's toxicology too, which you can do a 2 year fellowship and then you can go into kind of like the pharmaceutical world, or you could become uh, affiliated with a tox center or a poison center that may be located in your, but those are not everywhere. They are very few and far apart that they actually need physicians on call. Yeah.
Wow, I didn't know that emergency medicine had so many pathways. So, I understand that many ER resident physicians perform ultrasounds on their own patients. Are there any advantages of taking ultrasound yourself for POCUS investigations?
So, a long time ago when I trained, a long time ago when I trained, ultrasound was started off as being mandatory and you had to complete like an X amount of ultrasounds to do complete your fellowship, to complete your residency. Even now it's more extensive. Like they give more extensive lectures, they get more extensive amount. So I think when it comes to the medical aspects of the ultrasound, you will learn it in your emergency medicine residency. But the people who do the +1 ultrasound fellowship, mostly they're doing that so that they can gain some admin experience of how to start an ultrasound program or how to do billing for ultrasound and more different components of that technical aspects of ultrasound. Like they study more in depth about like what are the different ultrasound machines and which one helps in what different frequency and things like that. Things that I, as a regular emergency medicine, like as long as you give me a probe, I'll be like, yeah, I can use it. But some people who have done specific ultrasound, they would be very specific about what frequency does it work at, what are the different types of probes we can buy for the department. And usually somebody who's done an ultrasound fellowship will end up going on and becoming the ultrasound director, because we do need people to have some standard of like doing a Q&A on the images we do get so that there is like quality maintained by the department for what product we're giving out. Because depending on where you train and depending on where you go and what the hospital's rules are, you can either bill for your POCUS or not. So some places you're not allowed to bill it because they don't give you the credentialing for it. But some places, and this is just like between radiology and, because radiology usually does all these scans. So it depends upon like revenue and a lot of other political concepts. So basically, when you do that ultrasound fellowship, you're the one taking care of all of that.
Thank you, Dr. Ali. Now, what do you think was the hardest part of your journey to get to where you are today, and what do you think we should look out for as students entering this journey?
I think for me personally was trying to keep a balance between how much to study, how much time to spend on this versus also having a life. And I think that's always hard for everyone because you study and then you think, I have not studied enough. I need to study more. And especially like at least during my time, you didn't really have like now, step 1, step 2, they've changed it to like pass and fail. I don't remember which one has changed just to pass and fail. They have gotten rid of like the clinical skills aspect. So they have a couple of things I think that's harder, right? Because before we all would get a grade, right? You would get a percentage or a grade, and that would show how well you did. But now, if it's just pass and fail and everybody passes, then how does it really show the difference between people? So I think as you go up, it becomes harder to get into residency because then it's just not your grades anymore. It's all these other extracurricular activities that you do, which I think again puts a lot of strain on people to do more work. So I think there are a lot of components, and I feel like no matter how much you do, you always feel like, oh, I should have done more. because residency is hard. And I think that's my one advice to people is that life will happen as you keep going. So make sure you take the time to live your life a little bit too. I was very young when I started my medical school. Like started my medical school right after high school because that's just how we do it back home. And I think at that point, like when I compare my experiences with somebody who did their medical school here or people who took gap years and things like that, it is a little different because I feel all I did was study, which is not bad. But I would tell people who think like, oh, all I'm doing is studying, take a minute if you feel that way because you want to make sure you're living life and doing things too.
I'm glad you mentioned all that. I just wanted to ask like a follow-up to that. How do you personally manage your work-life balance today and like with the random schedule hours and having multiple night shifts back to back? How do you manage all of that to keep your sanity?
It is definitely difficult, but I have realized that as long as you organize yourself pretty well, you're still very much able to do this. I was talking to Minahil about this. I had done like a bunch of night shifts and then I shifted to days and I did a bunch of days and then I jumped back to a night and then I came back. And so it's a lot of back and forth. And a lot of the time when the month starts, I make a very specific calendar of the days that I'm going to meal prep for. Basically, you want to make sure your basic needs are taken care of, right? So, food. For me, I'm not a big fan of eating like food from outside. So, having home food is a comfort for me, and that just makes me feel better in general. So, since that is a priority, I have days where I will meal prep and plan for a couple of my shifts. So, if I'm about to start a stretch of like 4 days, I will make sure I cook the day before, like make breakfast for all of those days, lunches for all of those days, and then I'll leave like some time out that if I just spontaneously feel like eating something, that's fine. Another component is that I really feel like I need to keep my mental health is to exercise. And even if it's just like walking out and about, that is enough for me. So I usually try and make sure at least 3 or 4 days of the week I'm doing something. If it's not strength training, it's just walking on a treadmill or walking outside, just something so that I'm getting some movement because I think that's very important. And lastly, I think it's sleep. I think if you don't sleep well, you can be a very cranky human being. So I try to ensure that I am, especially when I'm flipping and flopping, I try to make sure I have a specific rhythm what works for me better. Whether that's taking medications for sleeping or taking a calming tea or there are multiple different things that may work differently for people. And I have a routine down now for myself that I can do to like shut myself off and go to sleep. But yeah, there are days I still struggle with the flipping and the flopping. And I think anyone who's considering emergency medicine should think about that. If because when I was younger, I had no issue doing it, but I feel like as I've gotten older, it has gotten harder to be able to sleep. I also try to put in like every week, I try to put in a time where I talk to my parents or I spend time with my loved ones and I'll go out for a dinner with a friend or somebody that I want to hang out with and keep my personal relationships too. So I think having that balance of like maintaining that balance is important and having that balance is done if you organize things well. Uh, sure, you can still do a lot of things spontaneously, but they happen less like less than now when I was younger. Yeah.
Yeah, thank you, Dr. Ali. Self-care really is important, like prioritizing your needs because we're not machines. We need to do all these things like spending time with our loved ones and stuff like that. Like putting in the extra work, like meal prep helps you in the long term. You thank yourself later. So I really appreciated your advice and I hope to implement it myself as I go through this journey. I'm sure many of our students will as well. Our next question is, I know you mentioned that not all the patients you see are emergencies, but during busy days in the ER, do you feel like you normally have enough time to counsel patients?
So it depends on what they have come for, but so I like to say a goodbye to every patient. So what I do is when the labs and everything comes back, I do go back in there, I sit down and I try to go through all the lab work that has gone through with the patient, what we have done for the patient. And if there is anything specific that I feel I need to counsel on, then I will. For example, I have an interest in psychiatric emergency, and we do see a lot of people who will come in with anxiety or depression. And we do have a crisis evaluator who can talk to them. But I also take the minute to just sit down with them and show them how to do breathing exercises or talk to them about the safety plan, even after the crisis evaluator has done that. I think it also makes me feel a little bit better that I made sure this person was safe. The way that goodbye, when you do to somebody, like you sit down, you tell them like, hey, I just want to let you know we did all of this with you today, and all of this came back, and this is what happened, and this is what we think is going on. And these are the medications and things that we want you to take. It makes the patient feel better. It makes me feel better too, because now I've like make sure I've explained everything to patient, but it also makes the patient feels better. It makes them feel like we have taken care of them. So I do try to take that time. Sometimes it's just a 2-minute thing. Sometimes it may go off to 5 minutes. Sometimes it depends on like if the patient has more questions. It is a busy environment, but you have to learn to one thing I've learned is to compartmentalize, because every patient that you see has a different story. Like you may be telling somebody a good news, like they're pregnant, versus you may be telling another family member that someone died. So it's a lot of emotions that go from one to the other. So like what helps me is compartmentalizing everything and then going through one by one, and taking my time too while doing it. So I have to purposely slow myself down.
That's a really good tip. Thank you. I know it's important for like the patient to feel comfortable and make sure that everything has been handled, taken care of, tying up loose ends before they leave the emergency department. And as you mentioned, you immigrated from Dubai. What do you think is the best way for healthcare teams to be more inclusive and culturally competent with their fellow clinicians and physician colleagues who are IMGs?
So one thing I really struggled with when I moved here was I don't think a lot of people knew where I was from. I got a lot of questions like, is Dubai in India? Because I look Indian. So there were a lot of, I think, people just didn't understand or didn't know or didn't want to know sometimes. And I think that's where the concern is. That so I think asking people open-ended questions with curiosity is better than making an assumption of someone's belief. Um, Another thing is like, if you wear a hijab or a headscarf or things like that, there's an automatic biases that sometimes you can feel from other people depending on which part of the country you go to. So a lot of those components, I think, again, come from the fact that we need to be more open-minded, more inclusive, more understanding of other people's culture, and be respectful and tolerant as we learn about each other's space.
Yeah, I really appreciate that. I know a lot of people feel like uncomfortable at first to ask people questions like where you're from, tell me about it, but it's really important to build up that open environment where people can ask questions. We just have one more question for you. Our last question. What tips do you have for students who want to approach an ER doctor to shadow them in person? And what are some other resources you may recommend for students interested in pursuing emergency medicine?
So for shadowing, I think a lot of the schools may have some affiliation program. Like I know University of Maryland School of Medicine does have a shadowing program that you can apply for. And I think it's always easier if you apply through a shadowing program, because then the chances you will get accepted and go through would be easy. But you could also most academic programs do have a limit of who you are allowed to bring into the hospital as a volunteer or as a shadower outside of those programs if they already have something established. But if you know somebody in private practice or somebody who you don't really have emergency medicine with private practice, but it might be more of like a community setting where the rules may be a little bit different. If they don't have students and things like that, you may be able to shadow someone like that. And a lot of that, unfortunately, is through people and networking. It's hard to randomly find those unless you apply through a program. It is all through the people that you know that you might be able to connect with one doctor and they might be able to help you to connect with somebody else and move on and move forward. The resources, so we have the American College of Emergency Physicians and we have the American Academy of Emergency Medicine. They hold multiple webinars that talk extensively about what it is to not just be an emergency medicine physician, but also what the training looks like. What is the future out there after you finish your training? How does day-to-day life look like? They're good resources not only for learning about that, but also interacting with medical students there who who may be able to share their experiences. Both of them do have some sort of resident association and a medical student association. If you're interested early on and you know you want to go into emergency medicine, I would recommend um, being part of one of these because the friendships that you make along will last for a long time. And, even if you're in different aspects of your career, once you get into the residency and become an attending, you'll know these people and you'll connect with them and you can always keep in touch.
Thank you. That makes a lot of sense. Yeah, it is really about the people you know. So again, it's important for people to not be scared and to branch out and speak with people because you never know where one person might lead to your future, right? So yeah, I am chatting with Dr. Tran in the ED. So it's really interesting through at the Midtown Emergency Department. It's pretty nice experience so far. Thank you so much, Dr. Ali. We really appreciate you taking the time to answer all of our questions today and taking the time to mentor us with that amazing session. I'd love everyone to please give a warm thank you to Dr. Ellie in the chat box for this wonderful session. Thank you.
Thank you. Y'all are welcome.
Yeah. So now we're going to conduct our closing session with our quiz and future session dates. The link to the quiz for the session is now live, and again, you will need a 70% or higher to pass and receive certification. Our next session will be next Saturday, September 14th, and those dates will also be posted on our social media outlets, so be sure to follow us at TeleShadowing. Again, thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing. Thank you.